Thank you, sir. So our next speaker in sequence would be Dr. Shalini Mohan from Kanpur. She is professor of ophthalmology and in charge Central Zone of Glaucoma Society of India. She is a prolific anterior segment surgeon, and she will be throwing some insight on how our torics go wrong. So when we do good surgery and plan a toric IOL also, but sometimes it goes wrong. So what wrong happens and how to go about it, I think none better than Dr. Shalini can tell us. So please take charge, ma'am.
Thank you so much, Dr. Mohit Khatri, for having me here in this IC with such wonderful stalwarts sitting over here. So I'm going to talk about toric trouble. My toric went wrong. So I don't have any financial interest. So whenever we are planning surgery in our patient, what we want a very clear image. But what a astigmatic patient sees is actually like this when he should be seeing it clearly like this. Similarly, at night time, there is large amount of halos and glare happening with the patient who is astigmatic, and that is why we want to put toric IOLs. So there are a variety of methods to correct astigmatism, but the most established ones are these toric, which are available with variety of manufacturers. And we know that we need to calculate the toric IOL powers with the help of online calculators available. So these are the various parameters we need to fix in whenever we are calculating the flat axis, the steep axis, IOL power spherical equivalent along with surgically induced astigmatism and then incision location. Now we have to be very careful whenever we are planning our toric IOL while feeding in all the data. Moreover, whenever we are calculating the surgically induced astigmatism, it is very important to calculate for separately for right eye and for left eye, because it might vary, and you can easily do it with the websites available like drhill.com, or you can also give in your own data to the people who are providing you with IOL, and they can actually help you in calculating your surgically induced astigmatism. Now, this was a case of a 55-year-old female patient who presented to us with cataract. So, in preoperative evaluation, she was having a best corrected visual acuity of 3/60 with axial length of 25.01 and keratometric reading of 41.75 at the axis of 82, which was flatter, and 46.25, which was a steeper meridian, and this was a regular astigmatism of around 4.5 diopters. So, as we do for all our torics, we actually calculated, and a power of 6, we fed in all the data, and power of 16.5 came in with a type of lens that was T6 for the toric IOL. So reference marking we all do in sitting position, and there are a variety of methods, but the bubble marker is the one which we generally use. But with digital markers, it has become much easier. You need not to sit the patient, and you can do it on table itself. So the surgery went off well, and as we do for all our cases, we injected viscoelastic after marking, and then a nice circle CCC was done with the help of a cystitome, and it is important to make nice circular 5.5 rexes so that it equally completely equally covers the IOL from all the side. Patient was slightly uncooperative but not difficult to manage. But then this was hydrodissection and delineation. Phacoemulsification was being continued by direct chop method, by vertical chopping, and that was a good great nucleus and went off well. Now this was the epinuclear plate manipulation going on. So and then the lens was implanted. Now it is important to clear off all the fibrous matter, all the lens matter from the bag before implanting the IOL, so that you don't have any fibrosis later on which might change the axis of your torics. And then whenever you are using the OVDs, it is important to use a high viscosity OVDs, so that whenever you are removing it from beneath the IOL, you remove all of them together, and they actually don't cause problem in rotation which might happen in your patients. So that was a uneventful phacoemulsification with toric IOL implantation. First day post-operative anterior segment was satisfactory, but what happened to uncorrected visual acuity, which was only 3/60, and pinhole vision was just 5/60. So that was a kind of bad surprise for us, because we were expecting much good results for the patient. Fundus was absolutely normal, and then we checked the IOL power in pseudophakic mode. And what was happening to refraction? Refraction of the patient came to +4 diopters and -9 diopter cylinder. So actually it got reversed, which was -4.5 diopters a cylinder, and suddenly it got doubled. So now we started scratching our head. So we know that if there is a rotation of just 1 degree, there is 3.3% loss in the toric IOL powers. If it is 10-degree rotation, there is 1/3 loss of efficacy, and if it is 20-degree rotation, it is 2/3. So if your power IOL has rotated by 30-degree, it is complete loss of toric IOL efficacy in the patients in these IOLs. So now what has happened? The astigmatism actually doubled. So that was the problem, and that means the IOL rotated by 90-degree. So like we were puzzled, is it possible that the surgery we did and the IOL rotated by 90-degree? So we dilated the patient and we checked. The axis was exactly the same as we planned. So now what? There was no answer to any of us. Was the markings on the IOL that was wrong, or the data which was fed in, like flat axis was entered at the steep meridian? So we talked to manufacturers also, and they were ready to change the IOL. But then we thought, why not to go for a minimal manipulation? Why not to check and rotate? So we rotated the IOL by 90 degrees, and that actually gave us smiling patient. So sometimes it might not be your own fault, but there might be something else. Do think out of the box, and you can have some surprises like this also. So rotation is quite common. This was another patient we did, and this was the IOL was to be implanted at around 83 degrees, but then it actually went against that, and this was taken up for OT, and he was dialed. The thing is that how much rotation is to be done, that is very important, and for that you can actually calculate it from this website, which is astigmaticfix.com. You can feed in your data, your refraction, and then you can get how much rotation you have to do to get the accurate vision of 6/6. So is it rotation common with us only? Not at all. In fact, if you see various studies, there are published data that rotation depends on the power of torus, and that is bound to increase with amount of axis misalignment. In fact, early rotation is seen maximally within 24 hours. So do not forget to dilate your patient the very next day and then check about the markings, so that if there is problem, you can immediately manage the patient. Now this was a very good meta-analysis of 13 randomized control trials done on 707 eyes, and they found then on an average the toric IOLs rotated less than 5 degree, but then 1.1% of patients, they required surgical manipulation. So it is happening everywhere. We are not the only ones. Now this was the comparison of various types of IOL, in which it was seen that I don't have any financial interest, but they showed that 3% was seen with Acrisoft lenses, 20% with Star, 9% with Microsil, and 13% with Rayner IOLs. Well, so there are certain golden rules to avoid this rotation and to get good rotational stability. First and foremost thing is be meticulous with your wound construction. The good wound construction actually helps in stabilizing the anterior chamber and therefore preventing the rotation. Then as I mentioned, well-centered capsulotomy is actually is a way to go. And then the position of IOL should be in very clean capsule. Do not leave any fibrotic band, and then use cohesive OVD. The fifth golden rule which I used is that hydrate the wound to seal normally, but don't over pressurize. Neither the high should be hypotenuse. So it should be adequately sealed wound, which actually gives you a good placement of IOL. So where can we all go wrong? As we saw, there can be problem with preoperative measurements. Then there can be preoperative assessment error, like Dr. Anaga showed. There can be dry eyes and you can actually make measurements error. Then there can be incorrect markings on cornea. There can be incorrect placement of IOL. Then calculation of CI is equally important, and as I said, it should be done separately for right eye and left eye. And then another very important thing which sometimes we tend to miss is about posterior keratometric astigmatism. So for that, if you can take into account the posterior keratometric astigmatism, that actually helps to curb the problem. Now this is another very interesting case where IOL power calculation, toric calculation was done for this was a Zeiss lens, and you can see the axis of placement is 161 degree, but when these data were fed in another calculator, the axis came to 171 degree. The thing is that whenever you are planning your surgery, suppose you are using a manufacturer's IOL, use same online calculator for that particular IOL. Like if you are going for a Alcon lens, go for Alcon toric calculator. If you are using a Zeiss lens, go for Zeiss calculator, because if you feed in the data in different, you might get a different axis placement, and that might actually lead to problems in the post-operative thing. So use same calculator as same IOL brand. Now, torics in post-PK patient is another thing, whether you should go about it or not. So, if you have a regular astigmatism after 3 months after removal of all your sutures, then you can definitely implant in toric IOL. But if it is a irregular astigmatism given different reading in on all topography and IOL masters readings, so better not to go for torics. In glaucoma patients, if you have a previous trabeculectomy done, it is okay to go for torics IOL. But if you are doing a combined surgery like phacotrabeculectomy, you are expecting shallowness in anterior chamber, better not to do toric IOL. So the take-home message is that toric IOL, they are definitely very rewarding and they good very wow factor to the patient. But certain things which we must incorporate to get a smiling patient is that accurate measurement, accurate calculation, accurate marking and accurate positioning of IOL is very, very important. Thank you so much for your kind attention.
Thank you, ma'am, for your comprehensive presentation, and that was very informative. Very fine points brought forward, especially SIA for two different eyes is different, using the same brand calculator for the torics and many others. And allied surgeries, if you are going a phacotrab or post PK, then those were also highlighted. So that's really incredible, and we are happy to have you here, ma'am. And moving next